now. Good evening. So, welcome to the latest episode of the Pharmacy Lounge podcast. So, today's topic is really about how to be a DPP. What makes a really great DPP, a designated prescribing practitioner. So we're getting close to 2026, and more of us will be looking to become an independent prescriber. That will be looking to find DPP or DMP. So that just out of the main difference between DMP and DPP is a DMP is usually a doctor, a GP, whereas DPP can be anyone who isn't a doctor. So a pharmacist or a nurse can be a DPP. Usually, if you're going to be a pharmacist and you want to become an independent prescriber, you really want your DPP to be a pharmacist. Now, a lot of people do go for GPs because obviously they have a lot of experience in prescribing, but there's also the view that if you're a pharmacist and you want to become a prescriber, you really should try and learn from a pharmacist who's got a lot of experience, because we see things differently to how GPs would see it. Well, we come from a slightly different angle where, we come from the actual pharmacy side, whereas GPs will come from the diagnostic side. So there is two schools of thought on who you should really go for and who you'd be most benefit from. And both sides will have some really great arguments for it. But I think tonight what we want to kind of clarify to anyone who, first of all, wants to become a DPP is, apart from the minimum requirements to become a DPP, what actually sets you apart from the average prescriber, and how do you really teach your trainees to think independently and really understand what they're doing. I mean, a 6 months course isn't long enough to make you an expert in prescribing. It gives you the basics. So, how do you get your trainees to really be good at prescribing once they pass? And also the other side of it is, if you're a pharmacist looking for a DPP, what are the things you should be looking for in a really good DPP? So with that in mind, we've got Antonio Monacello, who's an experienced ACP, and we've also got Siddiq Rahman, who's is about to take his first IP trainee. So I'm going to start off with Antonio to kind of go through the basics of becoming a DPP and talk about his experience you had 6 students so far. So, what was the learning experience and what he feels is the best, what's the best way to get the most out of the training. So over to you, Antonio.
Hi, yeah. So obviously, thank you for the introduction, Mohammed. So my name's Antonio. I've worked as an independent prescriber now for about 8 years. I've been a qualified pharmacist for about 10 or 12, and I'm also an ACP. So as Mohammed already mentioned, I've had 6 DPP students, 6 prescribing students, but I've also had sort of 3 pre-regs and 2 ACP students come through my wings, as it were. In terms of the prerequisites, the minimum requirements, there isn't actually any stipulated by the GPHC, but most prescribing programs are influenced by RPS guidance, and that obviously normally stipulates at least a minimum of 3 years of active prescribing, and thus most prescribing programs should follow the same guidance. I mean, the only caveat I'd put on that is it's very, very possible to have been practicing in an area for a long period of time without having the actual prescribing qualification. And you can still influence sort of prescribing decisions. You might need to get the medicine or medicine changed or the treatment approved by a GP or a registered prescriber. So that might be an exception to the rule. But if you haven't actually been prescribing, you'll find it very difficult to be accepted as a DPP on any prescribing program. But for myself, I think probably the most important thing to have as a professional and personally is a joy for teaching others and sharing learning. That's something I've always had a passion for. I've always really enjoyed, because one, it really helps me to reflect upon my own practice, but I also find it very rewarding to see other professionals progress, whether they're a nurse, a pharmacist, or technician. I think it's part of our code of conduct as well, is to impart learning and to help support the profession and others. But other than that, it's actually having the time. You need to have the time to give to your student. You're ultimately responsible for their training. You're going to impart them on to the public, and they're going to make prescribing decisions that can affect the health and well-being of someone's mother, father. It's people's families ultimately that you're family members and loved ones you're dealing with. I wouldn't want anyone to be treating my mother who hasn't got the relevant experience or knowledge or passion for what they do. In terms of the actual area of expertise, I mean, there's lots of postgraduate qualifications you can do in prescribing areas, and I certainly think further education around your area of competence is important. It doesn't necessarily need to be a diploma, but certainly for areas like diabetes, you need to have done some form of diploma or postgraduate qualification, because they're very, very broad modules. And you need to have had a good 2 to 3 years experience actually, managing patients in this particular field before you can competently, I think, run clinics. Competent is a very vague term. What determines competence? But I think, if you can confidently have a patient in front of you, they've got a diagnosis, that you've got their bloods, and you can understand all of those different parameters, and then confidently know what you do in the next steps according to national and local guidelines, you are probably competent to then train others to do so. In terms of what I would look for in a DPP, someone that gives you the time. As pharmacy professionals, we're very risk averse. That comes as part of our training. We're taught from day one at university that if you make a single error, you could end up being struck off and end up in prison, which to some extent is true, but it's not entirely. So you need to be able to provide an environment where people have the confidence to practice their prescribing skills, knowing that they've got you there to safety net them and support. And I often do that in what we call a virtual clinic type environment. So I'll have a patient that we're about to call, with some idea of what the problem is, and I would discuss the plan with the student I have in front of me, ask what they would do, and we'd decide whether that's appropriate or what I would do differently or what should be done differently. And then call the patient, and I would let the student lead on that. Once they're comfortable in the environment, once they've shadowed me for 2 to 3 sessions, lead the consultation with myself there as sort of guidance. Obviously, that's with patient consent, and you obviously inform the patient first before the actual consultation starts. And you'll find most patients are, they're very open to that. They're very happy with that. They'll say, well, that's how you learn. Occasionally, patients will throw a curveball at you, and the consultation is totally derailed, and the problem presenting in front of you is completely different to what you initially anticipated. But again, that's part of being a competent prescriber. You need to be able to adapt to your plans and change. And I think that's what sets you apart from having the experience just to give a medicine versus being able to prescribe competently. You need to be able to adjust and react to the different variables that can come your way. I hope that gives everyone a brief, introduction to what it would take to be a good DPP and what sort of requirements are and what you should perhaps look for. Find someone that's going to give you the time. They're passionate about teaching others, and you'll see that in the way they work. Not perhaps someone that just sits you there and doesn't let you do anything, always using it as a means just to make some income. Is there anything you'd like to add to that, Sadiq? Or
that's a pretty good solid introduction as well there, Antonio. I'm about to embark on my DP journey. I've got a decent pharmacist that I've been working with for the past 2 years, who's done the CPP pathway and is now doing the funded IP course. And so it makes sense, having worked with for the last 2 years, my practices that I want to start my DP journey. I'm feeling a bit more confident as well as being a prescriber for the last 4 years as well. And in terms of becoming a DP, I think it's important that you create a safe learning culture as well within your practices, and it's not just you yourself as a DPP and a student, but also your whole team that you work with. So I've had the experience of supervising not just pharmacists, but other healthcare professionals, such as nurses, paramedics, physios, who've come to my practices from secondary care settings just to see how we work in primary care, what does a pharmacist do, and how I utilize my consultation skills and my prescribing decisions, because it's not just prescribing medications, also the non-prescribing element is just as important as well. And that's what I want to instill into my potential students as well as a DPP, because one of the things as a potential student is when you are doing the course, you're going to have to do a portfolio, which is a series of reflective learning and essays. And the more variety that you see, not just with your DMPs or DPPs, but also with other clinicians as well, and the more varied you are, then you've got more content to write for your portfolio as well.
Yeah, I think, and I might just add to that, like you said, it's about considering, all angles, and certainly you want a DPP that can give you experience and, shadowing a lot of other professionals, because we all approach prescribing slightly differently, and our approach to the consultation, and then you can take aspects from different professionals and different, individuals and apply that to your own practice and build yourself up as a clinician in that way. I mean, I've certainly found it useful. I've learned lots from paramedics, from nurses, from doctors, and it adds to your skill set as a pharmacist and makes you a more well-rounded clinician. And certainly, you've got the more minor details, like someone that's going to teach you how to, properly document your notes. So I'm a strong believer that if I've got a consultation and I've logged it, someone else should then be able to come along, pick up where I left off, and quite clearly know what the next steps are or the follow-up plan. To keep that consistency and safety there. And like you said, creating a safe learning culture where you can comfortably practice and feel, confident in being able to practice your skills without being perhaps penalised for doing something wrong.
Yeah.
I think one question I think we get quite a lot is, should I go for a DMP or should I go for a DPP? And go for is it better to have a GP to train me, or is it better to have a pharmacist to train me? Where do you see that argument going? I mean, do you think it's the same, or do you think there's a clear difference between the two? Is one better than the other?
No, I don't think it is. I think it's very much individual. There's some fantastic GPs out there who are excellent at teaching. And they foster and develop the next generation of general practitioners. They have especially a training practice, and the same goes with pharmacists, nurses. I don't think any or will necessarily offer any real advantage. I know sort of GPs perhaps have got a more general global experience, but they may not have key experience in your area of the area of expertise you wish to focus on. There's GPs out there that I've sat on the same courses with, to learn how to practice effectively in diabetes, etc. I think it's very much based on the individual in front of you, who's going to give you the value, the time, and the space to actually, develop your skills, rather than whether they're a doctor, they're a nurse, etc.
Fair enough. Yeah. So,
I'd say in addition to that, I think it depends on the scope of practice that you choose as well, and who will be the most suitable clinician to act as your DMP or DPP. Because say if you're focusing on hypertension, you could either go for both, but if it's specifically niche, say for example substance misuse, then would it be a GP be the best person to go? Could it be a pharmacist already running these clinics might be a better option. So it all depends on what your chosen scope of practice is. And I think, and regarding the scope of practice, just because you choose a specific clinical area for the purpose of the IPA course, it doesn't mean that's all you're going to focus on after the IP. You can expand your scope of practice afterwards. But I think one take-home message I would say is, for the purpose of the IP, select your clinician wisely in terms of your chosen scope of practice for the purpose of the IP course. Don't choose something so too niche out there. Just do something that you're going to enjoy, a clinical topic that you're going to be good at, and also have more access. And the second advice is, don't just rely on just that one clinician. I think what universities like is that you have variety as well. In those 90 clinical hours, I don't think that you're going to spend all those 90 clinical hours with just one clinician as your DMP, DPP. Spend sometimes with other clinicians as well, but obviously the majority should be with your DMP and DPP to supervise, just so that you have a broader knowledge of that chosen scope of practice.
Yeah.
Just got one question from Norman. Can you only become a DPP in your area of competence?
That's quite a good question, actually. I personally would say Yes, I mean, if your area of competence is diabetes and you've got someone who's wanting to be a prescriber in dermatology, they're so far apart that you can't really justify calling yourself a DPP for that student. However, there are certain overlaps. Hypertension ties in quite well with heart failure, with atrial fibrillation. There's also overlap there with diabetes. So you could potentially spend some of your hours with someone who hasn't got that area of competence as their sole expertise, but certainly for the focus of the course, they need to have experience in that particular disease state. Don't get me wrong, there's generalists. I mean, I practice in quite a few different areas, that I've built up over the years, COPD, respiratory. I do skin as well. I do minor illness, etc. But, if someone came to me and wanted to shadow me for, rheumatology, for example, I couldn't justify giving my time to them because it wouldn't give me the experience or time they need. I might do RA reviews, rheumatoid arthritis reviews in general practice, and perhaps titrate doses of certain medicines or treat exacerbations. But I'm not a rheumatologist or a rheumatologist specialist nurse, which I think you would need to be.
Yeah, and I think, to be honest, if I was looking for a DPP, I'd want someone who's basically spent the last 2, 3, 4 years prescribing in that specific area. So if I was going for diabetes and you've just started prescribing diabetes yourself, I'd rather have someone who's had years of experience in prescribing diabetes who actually does have in-depth knowledge. So if you're going to be a DPP, then stick to what you know. That at least then you can really teach in depth about that condition. But you can also be confident in teaching in the area. I think the one of the things I would probably say to anyone looking to become an IP is that just because you've done your IP and this is what Siddiqua said before, just because you've done your IP training in diabetes doesn't mean you can only prescribe in diabetes. I mean, that just is a very basic knowledge and qualification to enable you to prescribe in the area. Doesn't mean you should. There's still a lot to learn. And I think, and I want to get your opinion on this area. I mean, at what point would you say someone is competent? I mean, confidence comes with time and getting enough knowledge. But at what point would you say someone is competent to prescribe in an area? I mean, does it say how many hours of training or what level of training would someone need to go through?
No, I think that's again very hard to quantify. It's a bit like driving. We all pass, at different points. We all take slightly longer than others. It's again quite individual. I mean, like you said, the IP is just a piece of paper. Essentially, it doesn't necessarily give you the competence to then go out and prescribe in that area. I mean, ideally that would be the case, but they call it practicing medicine for a reason. You only really get that experience by actively engaging in treatment and practicing your skill set. I mean, if someone was to say to me, how do you quantify being a competent prescriber? I mean, if it was diabetes, for example, I would say, well, I've got a postgraduate qualification in diabetic management. I know what the requirements are to diagnose the condition. I know the surrounding considerations that need to be taken into account. Someone's ACR, their renal function, their blood pressure targets in that disease state. The treatment pathways, first line, second line, third line. How to initiate insulin confidently and up titrate and detitrate accordingly. And for the medicines that I prescribe, know the impact that will have on other conditions they have or other medication they take. And I think as a pharmacist, that's probably the easiest part. If you're going to prescribe metformin, you know what the interactions are, you know what their EGFR should be, etc. So if you could go into a clinic and say, right, I've got a patient in front of me, I've done his HbA1c, it's 56, I repeated it after 2 weeks, again it's 56. I would know I would comfortably be able to say, right, yes, you've got a diagnosis of type 2 diabetes. This is all the follow-up bloods we need to do. These are the agents we need to get you started on. This is a referral to the appropriate educational programs. Referral to the podiatrist, referral for a retinal screen. So you need to be able to consider everything that's related to that condition and what needs to be done in that consult confidently.
Yeah, that's fair enough. So I think I've got a question from Lyle Jones. What are the most common or the best areas to pick as an area of competence in the panel's opinion? Siddiqua, do you want to answer that one?
I will say, first of all, pick a specific clinical area that you enjoy and you like as well. Don't try to be too niche as well, because for the purpose of the IP course, they're not going to teach you the specific clinical scope of practice. They expect you to know that and to be running clinics on that. Basically for the IP course is they tell you how to write a prescription safely and legally. You got to remember, the prescribing course is not just for pharmacists; it's for other healthcare professionals. So although we have all the legislation and legalities and prescriptions under our belt because we've done that as part of our undergraduate course, the nurses, paramedics, physios, for example, they might not have had that same training. So, and this IP course is for all, not just specifically for pharmacists. And when you choose your scope of practice, you got to make sure you choose, as I say, not so difficult. And I think the common ones that I've seen, particularly from those coming from a community pharmacy setting, are hypertension, diabetes, and asthma. Those three, because they're three of the most common chronic conditions that patients have, and there's a lot of resources in those areas. So for me, I chose type 2 diabetes because it's not just about diabetes that you deal with patients. It is a cardiometabolic condition, so you got to manage their cholesterol, their high blood pressure, their kidney function as well. So it's got multiple chronic conditions that I can expand my scope other than focusing on diabetes only. And it could be similar for asthma. You could go into COPD, bronchiectasis. So as I said, for the scope of practice, choose probably the common condition clinics available, and you're more likely to get a DNP and particularly a DPP who are more focused on those specific clinical areas. But of course, if you're working in a hospital specialist setting where it's kidney function related or epilepsy specialist, then of course you choose that area. If you've got a hospital specialist acting as your DNP or DPP to look into that.
Yeah, I think building on that, I think as well is equally as important not to go too broad. You know, I've had people come to me saying, "Oh, I want to do my IP course in minor illness," but you know that encompasses multiple disease states. A raft of different pathologies, different medications. It'd be very hard to capture that within just a 6-month program. And bearing in mind, you could be examined on any one of those conditions, which range from coughs to worms to basic skin conditions. Because again, that's obviously quite a popular one in community pharmacy. What I have seen, I've seen people do their minor illness diploma alongside their prescribing course, and that tends to work quite well because they're complementary, and I suppose you get more than more bang for your buck from your DPP or DNP. So equally, you don't want to go too broad, you don't want to go too narrow. You need to find a good middle ground. And ideally, I would suggest if you're employed, it needs to have some value to your prescriber and patient cohort. If I've got a patient cohort and there's a real need for type 2 diabetes, I'm perhaps not going to be as useful if I then, go and do anticoagulation.
Yeah, so I think I suppose a lot of it depends on who you're going to be working for and where you're going to be working as well. But I think a lot of the newer, or a lot of people I think we're looking at, what can we do in community? Also with everyone going to be coming out as prescribers after 2026, there'll be a lot of push to start prescribing or setting up clinics in the community pharmacies. And I think that's one of the areas that the government is trying to push for, to turn pharmacies into small health clinics or small surgeries. So for someone who may be interested in either setting up private services or to working in community, is there any specific areas that they should be focusing on?
So this is where I suppose minor illness in community pharmacies are the real hot topic at the moment. There's talks around minor illness service, etc., being established anyway. But certainly, I see lots of people coming into community pharmacies wanting that service. If you were to do that, I would probably suggest that you do a minor illness diploma first or alongside it, and then you could probably comfortably be able to do the course and justify being able to prescribe in that area competently.
Okay. So there's a question from Pavan. Can you do, on UTI or Strep A? What can you do? Basically, can you do a Pavan? I think what you're trying to ask is, can you do a can we choose a course on one minor illness condition such as impetigo? Okay, so I think what he's trying to say is, can we do just one specific condition, a course on a specific condition? Assuming you can, right?
Most universities will come back and say no, and I'd probably say that's a justifiable response because it's just too narrow. I mean, if you're a prescriber, that's great, but if you can only prescribe for impetigo, your skill set isn't going to be used effectively for the resource that's been, the resource that's been invested into you. Whereas if someone else comes along and says, you know what, I want to do with ear, nose, and throat conditions, or predominantly, oral mucosal conditions or atopic conditions, they're more likely to get a place and probably employment that would allow them to use their skills. I mean, to illustrate the point, I remember I had one prescriber who got employed in a surgery in London. They would only prescribe in hypertension, and they would only prescribe amlodipine and benzoflumethiazide. And unfortunately, they were not kept on as a clinician because for the money they were being paid and the time that they had in clinic, there was just no return on the investment. So I would suggest that those conditions are fine as part of a wider area, but not solely, just UTIs.
Yeah, so I think, sorry, you say one something.
Add to that, yeah. Also, the difference between acute conditions and chronic conditions. Obviously, with the chronic conditions, there's a slightly wider scope to prescribing. But for acute condition, you can't just select just one acute condition and that's all you'll be prescribing for. I don't think that's sort of broad enough. You don't, you don't want to be too broad either. But for example, a good example would be ENT. If you concentrate on ears, nose, and throat, that would be a good scope of practice to focus on for prescribing. If you wanted to go down the minor illness route from a community pharmacy setting, but just UTIs on its own, I don't think that would be acceptable by most universities. And again, I would tend to agree with Antonio as well. So, but as I said, just a little bit broaden out if you want to get into the acute condition settings. And then, as we said earlier, that once you've done the prescribed qualification, you can expand it after that, provided you have the necessary clinical supervision and mentorship as well.
Yeah, so I think this is where I want to kind of, I had a question myself. So, say for example, I've done my IP course and I've done it on diabetes, but I want to work in community. I want to run a private clinic of dealing with sore throats, infections, and stuff like that. Would I need to? First of all, where are the best? Where would I be looking to learn more about these training on these topics? Do they have to be through university, or can it be just self-directed learning that I can do? Sorry, Sadiq, you want to come in?
If I start first, and I'm sure Antonio can add in afterwards. So the RPS have recently published a guidance about expanding your scope of practice if you're an existing prescriber. And one of the things they recommend, if you wanted to go in a total different clinical area, for the example you just mentioned, Doidel, you would need clinical supervision, because as I say, it's a totally different area than what you originally learned to prescribe in, as well as a mentorship, because how do you know the things that you're dealing with a different condition, that you're doing it correctly? Who's going to be supervising? Where are you going to ask questions if you get stuck as well?
Yeah, so this is where I want to get to, because a lot of people will then say, well, I've just done my IP course in diabetes because it was the only one I could get, but I'm really interested in dermatology, or I'm really interested in dealing with a specific ENT course, because I want to work in community or in a private clinic. How do I now move into this other area of practice?
As I say, there's qualifications available as well. Don't just do 1-2 day courses and think, you're fully competent. That's not it. A diploma, postgraduate courses are excellent, alongside with clinical supervision and mentorship. I think it's a combination of all three. If you want to prescribe in a different scope of practice, is what you need as a bare minimum. And the RPS guidance on that document reflects that as well.
Okay.
Yeah. I agree with Sadiq entirely. I think having the postgraduate qualification, that certainly underpins you from a medico-legal perspective and indemnity wise, so you don't necessarily need to have done another postgraduate degree in diabetes, but certainly a postgraduate diploma or certificate is a massive help. It gives you the foundations for that disease state anyway. And then the rest comes with experience and then clinical supervision and being signed off. Because people often forget as well, you need to know where the limits of your expertise lie. You need to know when to refer on and know what your red flags are. So a good example to draw on would be a diabetic patient. I had a patient I diagnosed with type 2 diabetes approximately 6 months ago. He was then seen by multiple clinicians since. He was losing a lot of weight. He had diarrhea, vomiting. Everyone he saw, GPs, nurses included, put it down to weight. Put it down to the metformin. But he lost 4 stone in 4 months. And I knew something wasn't right here. He was complaining of first, left upper right quadrant pain. So I sent him for an ultrasound, and unfortunately, lo and behold, he's got pancreatic CA that has spread to the liver, because I knew his symptoms and his disease progression was not accurate. I rechecked his HbA1c. Lo and behold, 6 months later, it was 140. So it's about knowing obviously I've reached the stage of my limitations. Then I know I'm not an oncologist. I know I need to then refer down the 2-week wait pathway to, gastro or upper GI and get him seen by someone who's got the relevant expertise. So you need to have knowledge, I think, as well of different referral routes that perhaps surround and link in with your conditions too. That's also important, and that comes under being part of the whole, MDT, multidisciplinary team. You can't just get someone and say, all right, if I've got a patient in front of me and I'm like, well, I don't really know what to do with this patient, I'm just going to sort of brush them off and then they can call back and see someone else. You need to really know who to be able to refer them on to call yourself competent and to practice safely.
Yeah, I agree with what Antonio said. I had a similar presentation as well for a newly diagnosed diabetic patients, but then the symptoms seem to get worse, and that it's not just about diabetes, not just about side effects of metformin. It's something more sinister going on, and know your red flags. And one thing that I've learned when I did my ACP courses is knowing your differentials, because that again through process of elimination you get down as to what type of condition that patient might actually have, and know the referral pathway, know who to refer to, and signpost. So as I said, you're a healthcare professional and you've got to know your own limits of competence, and again, knowing the differentials and the pathway doesn't make a big difference. And that's something that the IP course won't teach you. But again, working under clinical supervisors, working under MDD team, they will help as well. So, as a utilize other healthcare professionals where you can, rather than working silo, which is, I understand, is easier said than done, particularly if you're a community pharmacist.
Yeah, and I think that this is again the classic community pharmacy issue, isn't it? We work in a pharmacy on our own. There isn't another pharmacy that we very rarely ever work with, if ever. You sometimes get double cover, but then you're so busy you can't really talk to anyone else. But this is where again our clinical support group really comes in handy. If you've got any questions, ask. No question is stupid. So if you feel like you're not sure about something, you need to double check something. We have the clinical support group, we have the IP support group as well. So if it's more IP focused, join that group and feel free to ask questions. If you're a DPP yourself and you've got questions, we have got a separate DPP group as well. So there is a group for everything that on our network. So just ask questions, try networking, and share knowledge. And I think this is one of the things I really wanted to get the message out, in that we don't like for example doctors, they're constantly learning, they're constantly doing CPDs, they will invest in their own training and upskilling, something we don't really do as much, nowhere near as much as we should do. So I'd say go out and do more courses. There's a lot of clinical training providers. I think we work with a company called CPA on our network that advertise quite regularly. They got some really, really good courses. Have a look at those, but they're not the only ones. There's lots of other companies. I think there's one the GPs use, the Red Whale, is it? They have some really good training on there as well. So there are lots and lots of information out there. Spend time upskilling, spend time doing CPDs. Obviously, the more you know, the better it is for your patients, because then you can see these red flags well in advance, work with with the rest of the clinical support team, share your knowledge with the pharmacist. So, and obviously on Circle soon, we're going to be releasing an update where you can actually post these clinical questions to go out across the whole network. So we're trying to make it easier for you guys to ask those questions as well and to share that knowledge. So I think that's probably one of the key areas where I would say the area pharmacist really needs to focus on. Siddiq, Antonio, I mean, you guys can chime in and give your views on this as well. You know, how do you guys keep up to date with your relevant areas of expertise?
So I think I use every opportunity to learn, and I tap into all the resources available to me. So I work predominantly in general practice. You know, I might get a discharge letter from secondary care that's come from a specialist. I'll read that. You know, and you pick out key sort of gems that you didn't previously know. You add that into your repertoire. And do updates. So I've done my minor illness diploma that's RGN approved, but every 2 to 3 years I might go on a minor illness update course, which is, you know, generally only half a day or 1 day, but it just refreshes you and brings your knowledge up to date. You know, tap into the PJ and all these different resources as well that release, you know, regular clinical updates. I do work in lunches with reps, because again, they can quite often provide educational updates for you. They'll provide lunch and they'll be perhaps consultant led, and again give you updates on your sort of on your area, or indeed different areas. But other than that, there's no real secret to it. It's like you said, in taking the time to invest in your own development and learning, and, you know, tapping into the journals that are relevant to your field. And if you get the opportunity to learn from someone, take it. You know, you can learn from anyone and everybody. I mean, I've learned things from patients I didn't previously know, which perhaps probably shouldn't be the way it works, but you don't know who you're going to come.
Yeah, I think there's some really educated patients out there. I mean, my dad, he's constantly reading about, I mean, he's not a doctor, he's an accountant by profession, but he's always reading this kind of medical journals and stuff, and he'll come and ask me questions. I'm like, let me look that one up. So I think, yeah, sometimes you do get some questions. There's some patients that really know their stuff, and we even sometimes get them in pharmacies where they've done the research first, and then they'll come and ask you for your professional opinion on it. On some symptoms. So yeah, I think that's probably a key area. Siddiq, yeah, sure.
So as a prescriber, within my patch in my CCG, every year we have to fill in a prescriber scope of competence as well, and that's similar to what the PDA wants as an indemnity, that, you know, you've got evidence and documentation that you're keeping your knowledge up to date and learning. Again, that's part of your validation as well, anyway, as GPHC. There's a lot of trainee materials out there, is more than ever before when I first started. Some of them are free, some of them are paid ones. And I always think, you know, if you have to pay for the sessions, it's not money wasted, because it's investment into your learning and investment to help further your career. Especially working in general practice, it's not just diabetes I'm focusing in. It is general practice, and you could know broad clinical areas as well. So, for example, as part of the cough indicators, I have to do clinics on heart failure medication reviews. So I didn't want to just go in, just do medication review straight away. I wanted to invest my time into learning the whole pathology of heart failure. What is it? How do you treat it? How do you manage it? What are the red flags? Before I started to do this medication reviews, because it's not just about medication, it's about recognizing signs of worsening condition and who do you refer and signpost to. And so that I took time in my own time anyway to invest in specific training sessions and learning. And as Antonio mentioned as well, having a diploma course before I'm ready to tackle on into a different clinical area. And again, I mentioned that in my prescribing scope of practice, that I'm more confident in prescribing in that clinical condition because of the series of learning that I've undertaken beforehand. So, and as Tohodo, as you mentioned earlier, you know, you shouldn't be shy about having to pay for courses if it's something that you want to upskill, because other healthcare professionals, not just a healthcare professional, even other walks of life in other professions, if you want to further your career, if you want to upskill yourself, you sort of invest in your time and education anyway, if you want to go down that route. And I don't think pharmacists are any different.
Oh, and also you can claim if it's a paid course and you're a pharmacist, or if you're registered as a locum, then you can actually claim it back as an expense as well. So there is that. So Antonio, you want to say something?
Yeah, and I was just going to add as well. I think it's probably important to remember as well that we all want to learn, but don't run before you can walk. Take your time. I think that the future. I think certainly in the future there's going to be a lot of opportunity. I mean, certainly in general practice, we've moved from a GP ran model to a GP led model, now to a GP supervised model. So there's a big volume of space for other clinicians to fill and do a lot of the clinical work. So there's going to be lots of opportunity, I think, over the next 5 to 10 years to, develop and upskill yourself. You don't want too much too quickly, because I think that's where you're going to trip up. Get comfortable in 1 or 2 key disease states, and then, like Sadiq mentioned, start looking at the umbrella or branch areas. When you're doing diabetes, you might then look at optimizing someone's hypertensive regime, and that can start to lead you into the treating hypertension or hyperlipidemia, etc. So take your time, invest in your own learning. Hopefully your provider will provide you with some courses or funding. I mean, ultimately they should if they employ you, but I know that's not always the case.
So I think you got a question from you, to want to check whether they had it right, whether minor illness or minor illness was suggested as too broad. I think what he meant was, if you're going to be doing your IP training, pick something a bit more specific, like diabetes or hypertension, easier to do the exam. Whereas if you're doing your IP course on minor ailments, they could ask you questions from very, very broad areas of minor ailments. So it can be a bit more difficult area to pass your IP exam on. Am I right, Antonio?
Yeah, I think, sorry, to clarify the point I was making, if you've done your minor illness diploma and you've got background in that area, it's probably fine to do the IP course in it, because you're already working within that framework and you probably have a good knowledge of these disease states. But I've had people approach me who want to do their prescribing in minor illness with no prior experience in that field. Then I think it's a real minefield, because there is so much to learn and so many different pathologies, so many different disease states. When you've got something like hypertension or diabetes, the disease state is fairly consistent, and then you've just got your drug, your different treatments that you need to learn around that. But with minor illness, the treatments are all different, the pathophysiology is all different, and so the red flags. There's just too much to learn within 6 months. You could do it, but I think you're making life very hard for yourself. If you want to do it alongside your minor illness diploma, I think that's probably more sensible.
Okay, cool. I think that's. We'll try and wrap it up today, because I know some of our podcasts get really long. Right. So before we finish off, is there anyone that has any more questions? No. Okay. Yeah, nothing. I can't see anyone else typing anything. Okay, cool. That's fine. Do you guys want to add anything else before we finish off? Antonio, Sadiq?
I was going to say, I think Rasalba wanted us to clarify where the best places to get CBD courses are. I think postgraduate courses at universities are very good. If you want to do minor illness, there's 2 minor illness approved courses via the RGN. One is held at Oxford and one is held at Bedford, Red Whale, as Mohammed mentioned. But there's a lot of different providers. But try to look for those that have got perhaps some RGN approval or approval with a medically linked governing body, because it just makes it it holds a bit more weight, I think. That's all. Okay.
Sadiq, any last words?
It might be worth thinking about another session later on, I think, because I think we'll probably have a few more questions after the webinar as well, particularly about those who are wanting to become a DPP, because again, we know there's going to be pharmacists become prescriber ready from day one in 2026. There's still a whole dearth of current existing pharmacists that want to become prescribers, and they won't all be prescribers when 2026 comes around. So we need good quality pharmacists, DPPs, to be able to mentor those pharmacists. So again, it's probably not enough time to do it in this particular webinar, but I think it'd probably be a good idea to do, say, another podcast in terms of how you can become a DPP. Because I think, I know we had the funding recently from the Health Education England in terms of funding pharmacists to do the courses, but for me, that issue wasn't about funding the course. The issue for most community pharmacists and local pharmacists is actually having access to a DMP or DPP.
Yeah.
I think personally, it might be controversial, but again, here at the Pharmacist Cooperative, we've always been controversial. But the funding should be made for DMP and DPPs rather than the courses itself. Because I don't want to have money to give for everything, but I think at least increased opportunity for access would have been a breakthrough, I think, for community pharmacists. And I think they shouldn't just give the money to just any other prescribers. I think for them to have access to the funding, they need to do some sort of approved DPP training. But I think I'm starting to see universities doing the prescribing course are preferring some of the DPPs to do this teaching or training modules because even though you're a prescriber, how do you know you're going to become a good mentor? Have you ever done supervision before? Have you ever done given good quality feedback and appraisals? So that's a separate skill in itself as well. So I've had a few experiences before, which is why I'm in the position that I'm ready to become a DP. But I think that's just as important as well as becoming a mentor.
Sorry, Antonio, you want to?
Yeah, so two final points I want to make is if you are an IP looking for a DPP, find someone that's going to value you. If you have someone that will invest in you and give you that time, you can become an asset to them. My team, I have 4 pharmacists under me, but I work as part of a large organisation that employs over 300 people. My current ACP was my pre-reg, now my prescribing student, and now an ACP, and so are the others. And that's allowed me to then offload a lot of my day-to-day work, delegate appropriately, and because I've got that support network structure underneath me, I'm able to perform my role, which is as clinical director, much more effectively and make those key decisions. And equally, I wouldn't advise anyone become a DPP unless you've got the time and passion and energy to teach your fellow colleagues and actually want to see people better themselves, because I get a real reward from seeing that, seeing people develop, move on and better themselves. And then, it has a ripple effect to those around you and ultimately for your patients, because we all do this job, I would hope, to make a difference and help people. I think if you don't, you're probably in the wrong field. And, the patient outcomes ultimately come from the skill and experience and the passion of the clinician, and that's what you are passing on to the next generation of individuals, as it were.
Yeah, and I think from final few points for myself is that if you're a DPP and obviously you are going to be giving up your time. If we go to a GP to become our DMP, some of them will charge £3,000 to £5,000. And we've previously been discouraged from charging a fee for to become a trainee. But to be honest, if you're investing your time, you're taking the risk, you're teaching someone, I think it's only fair that DPPs charge for it. And if you're an IP looking for a DPP, don't think that you want to get someone who's free. Something that's free doesn't have value. Someone who's going to be doing something for free isn't going to be giving you as much time, or is not obligated to give you as much time and energy as someone who's being paid for a service. So you are paying for their time, you're paying for the quality of the training that you're going to receive. And I've had a lot of messages saying, "Oh yeah, I'm going to try and find someone free." Yeah, if you can find someone free, that's great. But someone who's going to go through the trouble of becoming a DPP, jumping through all these hoops, they need to be rewarded as well. So I think it is only fair that we pay someone for that. You don't go to university and get a free degree. It is paid for, whether it's by yourself or by the government. It is paid for. So everything has a value. So it just depends how much value do you place on your IP training.
Yeah, I think building on that, sorry, were you finished, Mohammed?
Yeah.
I think as well, it's important to the fee I generally find is anywhere from £1,000 to £1,500. Like Mohammed said, you're paying for the person's time, their experience, their skill set. It's 90 hours you get from them, but it isn't just the 90 hours you spend shadowing them. I have my students call me up at the weekend or in the evenings because they've got a clinical question, or they need help with an assignment. There's a lot of time that goes into the teaching someone that lies outside of those 90 hours. And certainly, I've got people that qualified 1-2 years ago, and they still send me a message and want my input. It's equally important that the teaching and learning from your DPP doesn't just stop at the day you get your certificate. It then continues into the future, past the point of being qualified. I think that's also important to remember. If you've got a good DPP, you've got a mentor there for life, as it were. So
yeah. So right, I think we're almost at 6 o'clock today. So guys, thanks for coming in. We're going to be posting this on YouTube as well. So if you missed most of it, or if you've joined in later on, you can listen to it on there. Or if you want to share it with everyone else as well. Please feel free to share it. So we will be doing a follow-up podcast on this. So if you've got any further questions, so you can send them over to me. We'll try and write up a full list of questions, and we'll try and do a Q&A and just go through all of those again. So Sidiko, Antonio, thank you for your time. Thank you for coming in today and sharing your knowledge with us. And we'll see you guys in the next one. Good night.
Good night, Rob.